Well, thank you, Richard, and hello, everyone. For the next 15 minutes, I'm going to do a little time traveling with you. I'm going to take you back 5 years to spring of 2020, and if I'm shown a red card, I might try some time traveling and go back 5 minutes to get a bit more time too. So, what I'm going to do is to address 4 key questions. What was known about COVID-19, and I'm going to take at face value that there was a disease called COVID-19, and I'm going to take at face value the official data that was coming out at the time, and then consider, in the light of that, even taking all of those, believing all of that, was it reasonable that we locked down, we did what we did? So the questions are, what did we know about COVID-19 in the spring of 2020? And I'm using the 24th of March, the first day of the first Scottish lockdown, as the cut-off point. In the light of that information, was it true that we faced a health emergency? What was the accepted approach to responding to pandemics? And what was in our pandemic plans? And then I'm going to compare that with what we actually did. So, question 1. Well, there seemed to be a pneumonia of unknown origin identified in Wuhan in December 2019. Over the following weeks and months, we learned more about the symptoms, which Richard has mentioned, which overlap with other respiratory diseases. We learned about the clinical signs and investigations, and a bit about treatment options too. And then, importantly, over that 3-month period, the spring of 2020, data started to emerge about the mortality and what we call epidemiological characteristics. So this is some of the mortality estimates. The first line, there was a 1-page report, the earliest I could find, which showed that the Chinese authorities had identified 259 deaths, about 12,000 cases, giving a case fatality rate of 2.2%. 3 weeks later, more cases, more deaths, unfortunately, but a similar case fatality rate. The third line there was the output from the WHO China Joint Mission, which reported at the end of February, and again more deaths, more cases, and a slightly higher fatality rate. And then at the bottom, I'm sure you remember the Diamond Princess, the cruise ship which was quarantined off a port in Japan. And they noted 7 deaths amongst 300 cases. And what's helpful about Diamond Princess is that they also went on to do a lot more testing of passengers and the staff. But they came up initially with a case fatality rate very similar to the reports from China. However, we need to understand the limitations of case fatality rates. They usually emerge when we have a new disease from hospitals, and they count, the clinicians who recognise it in hospital, count the number of deaths, they count the number of cases, they put one over the other and give us the case fatality rate. But what they don't, and that statistic doesn't give us, is potentially a far larger number of people out in the community with an infection. They will never, most of them have mild disease, they will never, hopefully, end up in hospital. So it gives us an inflated sense of the impact of any disease. What we really need to know is the infection fatality rate. And the Diamond Princess was the first, gave us the first estimate of the infection fatality rate, because they, in their widespread testing amongst all passengers and staff, they identified another 300 infected people, which reduces the apparent mortality rate and gives us the first estimate of infection fatality rate of 1.1%, less than half of the case fatality rate. Then the Imperial team from London, they looked at this and they produced another estimate of infection fatality rate using Chinese data, but they estimated the infection prevalence within the Chinese population, the main population, and they came up with a rate of 0.66. And then the last line there is my rough estimate. I've used the case fatality rate and then calculated an infection fatality rate using a figure that appears in the UK pandemic strategy. There they said between 1 and 4% of pandemic flu cases are admitted to hospital. So I used that figure to arrive at this estimate, the lowest estimate of 0.15. And even if you assume 1 in 10, not 4%, but 1 in 10% of people with COVID are admitted, you still only get to an infection fatality rate of 0.38. So my conclusion from this is that the IFR is below 1%. Or to look at it the other way around, 99% of people survive. So this data I've taken from the second Chinese reference, and they concluded that this disease was highly contagious. Most people have mild symptoms. They described the case fatality rate as low, and they noted that most deaths occurred in people over 60 and those with comorbidities, with chronic diseases. And you can see the youngest age group had a case fatality rate of 0.2, the oldest 14.8. But even in that old group, that oldest group, about 15% succumbed, but 85% survived. And the comorbidities, the highest was 10.5 cardiovascular disease, without any comorbidity, 0.9. This chart on the right is taken from the very first Italian National Health Institute report, and it shows that men are at higher risk. This is the numbers of deaths, not the rates. Men are in blue and women in red, so men have a higher risk. And the other thing it shows is the very steep age stratification. So the 3 bars on the left you can hardly see are below 60. The 4 bars on the right are above 60. So very few deaths below 60. And if you're fortunate to be below 60 and not have any diseases, your risk is extremely low. So, question 2. Was this a health emergency? Well, one of the ways anyway of doing this, assessing this, is to compare it with previous pandemics. So on the top we have Spanish flu, which had an IFR of between 3 and 8%. Asian and Hong Kong flus were far less, far lower mortality rates. Swine flu reasonably low too. However, moving to coronaviruses, SARS had a high case fatality rate, 3 to 28%, huge variation in different parts, the 4 countries that it appeared in. MERS, Middle East Respiratory Syndrome, 42% case fatality rate, extremely serious disease, IFR estimated to be 22%. By comparison, COVID, particularly with an IFR below 1%, it's certainly no Spanish flu, it's no, in terms of mortality rate, no SARS, no MERS. It's more like Asian or Hong Kong flu. So my conclusion is, if it was a health emergency, it wasn't a dire one. So I'm moving on here to question 3. I'm going to take that in 2 sections. This slide looks at measures to reduce transmission. And these are the standard public health measures for respiratory viruses. Respiratory and hand hygiene, use a tissue, cough or sneeze into a tissue, afterwards discard it, wash your hands. Isolate those with symptoms to stop onward transmission to others. Contact tracing not thought to be effective, not much evidence for that, except in the very earliest phases. Mask wearing only for healthcare staff. Potential school closures early on, but not thereafter, and that's simply because in flu, children are known to be super spreaders. Not evidence of that with COVID-19. Accurate public health messaging so we avoid panic. We'll hear a bit from Diane about whether we were successful in doing that. Tailored messaging for at-risk groups, high-risk groups. That didn't, though, amount to shielding or focused protection, so it fell short of that. And these measures were based upon evidence, based upon systematic reviews of the evidence, like the Cochrane review on the top right, and the WHO review on the bottom right. And that WHO review was published in autumn 2019, just a few months before the pandemic started. And this is some quotes from the UK pandemic strategy to give you a flavour of this document. It won't be possible to halt the spread of a pandemic flu virus. During the pandemic, we'll encourage those who are well to carry on as normal. We need to put in place plans and responses which are proportionate, and we need to take greater account of age-specific differences. And last, the response will be evidence-based and based on ethical principles. Well, we'll hear a bit more about evidence from Claire later on today, and ethical principles from Liz. So, question 4A, how did we do on the measures to reduce transmission compared to what was in our plans? The hygiene measures were straightforward. Isolation, we went way beyond isolating those with symptoms. We isolated everyone with a positive test. And there are problems, as you heard from Richard, with this test. In certain phases of the pandemic, there were certainly far more false positives than real, true cases. So we were isolating people when we didn't need to do that. We had very widespread contact tracing despite evidence, and that continued for most of the pandemic, and we isolated cases too. So we were isolating thousands and thousands of people unnecessarily. And then we advocated general community mask wearing, even for children who weren't at significant risk, and social distancing. We closed schools and we closed universities, having huge impacts on education. We, being diplomatic here, the information to the public wasn't always accurate. I should have said the content wasn't always appropriate as well. And certainly it did raise concerns and alarms. We shielded people in the high-risk groups, which was very good, but we went on to lock down businesses, society, and people and the NHS, and without a cost-benefit analysis. So we went well beyond the pandemic plans. So you'll remember the daily broadcast from Nicola Sturgeon and Boris Johnson, the endless charts from Whitty and Valance. Whenever you went out of the house, you were conscious of the police watching you. Empty roads, and in Northern Ireland, you won't be aware of this one, they even had social distancing for cars. So, question 3B, measures to protect and treat individuals. Traditionally, what we did was we vaccinated health and social care staff and vulnerable groups. If we had evidence, we gave antivirals to at-risk groups, and we provided symptomatic support in hospital, particularly for those with serious illness, including antibiotics for secondary prevention. By comparison, in the actual COVID response, we vaccinated virtually the whole population, despite not having very good evidence on effectiveness nor safety. We didn't emphasize that obesity increases risk or vitamin D might reduce risk. We did use antivirals, but we didn't use repurposed drugs for early treatment to prevent deterioration, despite having moderate quality evidence that they were effective. And then coming to the symptomatic support, we provided that, but we didn't always provide antibiotics for secondary bacterial infection. We applied do not resuscitate orders without consent in some cases, and we used midazolam and morphine perhaps when we shouldn't have done. So significant departures. So these are my conclusions. Early case fatality rate estimates were around 2.3%, but IFR much lower, below 1%. High risk groups were clearly defined, so most people weren't at risk. And therefore, it seems to me there was no need to depart from the usual response, except for shielding of high risk groups. And I just wanted to emphasize the last point that the accepted responses were evidence-based and lockdown harms were actually predicted. Thank you very much.